So I'm now talking about colorectal cancer, which is the fourth most frequently diagnosed cancer in the U.S. After breast and prostate, and after lung. And in terms of new cases, there's a fairly even distribution between new cases diagnosed between men and women, and a fairly even distribution among colorectal cancer-related deaths between men and women. Here is our figures demonstrating the annual age-adjusted incidence rates for colorectal cancer. And I'm showing this to you to just show you that over the last 30 years or so, we've seen pretty significant decreases actually in many of the cancers. If I can't figure out the, well, the blue line is for colorectal cancer. So really since the 1970s, you can see the time axis on the horizontal line and the rate per 100,000 along the vertical line. And this is really true for many cancers, but particularly for colorectal. Similarly, death rates for men and for women, colorectal is still in that bright blue line, are decreasing over the last 3 decades. But what I want to kind of highlight are some issues sort of Marcia brought up in her keynote talk are, though those rates look very similar, 48 and 52%, are there some hidden differences in patterns among sexes? And I think just to point out a few. So women greater than the age of 65 actually show higher mortality and lower 5-year survival of colorectal cancer compared with age-matched controls. And a higher proportion of women actually have right-sided colon cancers. So colon cancers can be diagnosed throughout the colon. Just to make a comment on this, there are a number of different screening tools which we'll talk about, one of which is sigmoidoscopy. A sigmoidoscopy only evaluates the left side of the colon and would be ignoring the right side of the colon. A full colonoscopy evaluates the entire colon. And then a recent cohort study indicated that risk of proximal, so those are tumors kind of closer to the small intestine, and those are the right-sided tumors. The risk of proximal large polyps increases with age, female sex, and Black race. So I think we're missing some of the nuances if we just look at those pooled numbers for incidence and death rates. I'm going to build on a figure that actually Allison showed that goes from normal tissue to cancer tissue to advanced stage. And this has actually been very well known for many years for colon cancer. We know that colon cancer actually starts with a precursor lesion, a precancerous lesion called a polyp. It then, over a period of many years, there are a number of molecular or genetic changes that build over time, and then that allows that polyp to become a cancer. And then over time, that cancer itself grows and can spread through the blood or through the lymph system and become an advanced stage. And so what this shows here are a number of genetic changes. So these lightning bolts are the genetic changes that build over time. And you can see that along the bottom here, the genetic instability also progressively increases over time, and thus a cancer develops. The types of molecular genetic changes have also been very well described for colon cancer. Back in the 1980s, a researcher by the name of Vogelstein described this phenomenon called the adenoma carcinoma sequence. And early colorectal cancer detection, so though we like to prevent cancer from forming, once it does become a cancer, we know that early detection of a cancer does in fact improve survival. So the figure on the left of your screen demonstrates proportions of localized, regional, and distant colorectal cancer by all races and then separated by white and black. And as you can see, approximately 20% of patients have advanced disease at the time of diagnosis. And on the right of your screen is a picture of something called a survival curve. So time is on the horizontal axis and the survival rate is on the vertical axis. So the figure in the line in red is actually patients with advanced disease, meaning that if we detect a cancer much later, their survival is much less than along the purple line along the top than if we detect it at a much earlier stage. So risk factors, moving on for colorectal cancer, do overlap some with some of the other cancers we've been talking about today. So for colorectal cancer in particular, age greater than 50, a personal history of colorectal cancer, and we're going to go into some of these in a little bit more detail, a family history of colorectal cancer, diabetes or insulin resistance, inflammatory bowel disease, which are conditions that include ulcerative colitis and Crohn's disease, inflammatory conditions of the bowel, and then modifiable risk factors such as a high-fat, low-fiber diet, tobacco use, alcohol, and sedentary lifestyle, which is something that Marcia spoke about earlier. So in terms of lifetime risk of colorectal cancer and these risk factors, let's just put some of them into perspective. So for the general population, the lifetime risk is about 5%. If someone has a personal history of colorectal cancer, they have about a 20% risk of developing another colorectal cancer. If they have inflammatory bowel disease, they have a risk of about 40%. HNPCC and FAP are both types of inherited conditions that can predispose to colorectal cancer, and those have a considerable increased lifetime risk of colorectal cancer. And we'll talk about those in the context of what Allison talked about, Allison Kurian, in terms of genetic risk. So in terms of inherited risk and family history, the large majority of patients with colorectal cancer actually are sporadic. So if you can think back to that picture that Allison showed of the kind of inheriting chromosomes from your parents, the large majority of patients with colorectal cancer inherit normal genes but then acquire some mutation over time that then predisposes them to colorectal cancer. Many of these have a family history, about 10 to 30%, and we don't yet know what inherited genes may predispose them to colon cancer. About 5% of patients have a condition called hereditary non-polyposis colon cancer, or Lynch syndrome, and another 1% have another inherited condition called FAP, or familial adenomatous polyposis, and there are some other rare syndromes as well. Lynch syndrome is probably worth talking about just briefly, and it is an autosomal dominant disorder, meaning you have to inherit genes from both parents in order to acquire this condition, and it's caused by mutations in genes that are called mismatch repair genes. And these can actually, inheriting this condition can actually predispose to cancers in a number of different organs, not just the colon. And this may have been discussed earlier in the gynecologic oncology section, but can include colon cancer, endometrial cancer, ovarian cancer, and a number of other cancers that are listed here. So mismatch repair, so what does that mean? So a defect in mismatch repair can lead to DNA damage. This defect causes a number of different new short repetitive DNA sequences that are called microsatellites. And these microsatellites lead to the loss of a protein that we can then measure. We can measure that in the DNA and can test for that. And there are a number of guidelines that help tell us, well, which patients of ours do we actually need to test for this microsatellite instability or these short repetitive DNA sequences. The revised Bethesda Guidelines indicate which patients need to have this MSI testing done. So colorectal cancer under the age of 50, patients who have synchronous or metachronous colorectal or Lynch syndrome associated tumors. So synchronous means diagnosed at the same time, or metachronous, diagnosed at different times. Lynch syndrome tumors. Colorectal cancer with that MSI high-like histology in a patient under 60. Colorectal cancer with one or more first-degree relatives with colorectal cancer or another Lynch syndrome tumor. And then lastly, a colorectal cancer with two or more relatives with colorectal cancer or another Lynch syndrome tumor, regardless of age. At Stanford, and actually in many places across the U.S., they've instituted pretty universal screening for microsatellite instability in patients under the age of 70. This is routinely done at Stanford and is done so at a number of other institutions. And I think, as Allison mentioned, for the BRCA testing, this has really created a huge influx of work for our genetics counselors, because we have to appropriately be able to counsel patients on what this means. The Amsterdam criteria are sort of partnered with the Bethesda criteria. These are a clinical criteria for who we might consider that we need to think about Lynch syndrome. So the Bethesda are preferred, though this is another tool that we can use to identify patients. So greater than 3 relatives with this Lynch syndrome associated cancer, one of whom is a first-degree relative. cancers involving at least 2 generations, and 1 or more cancers diagnosed before the age of 50. Now, to talk specifically about screening tools, we'll talk a little bit about screening in the average risk patient and some in the high risk patient, like those folks that we've just talked about who may have inherited risks that predispose them to a much higher risk of developing colon cancer. But our screening tools fall into 2 main categories. There are these structural or endoscopic tools, and I'll disclose my husband's a gastroenterologist, so I hear a lot about this at home. And then there are also fecal or stool-based tests. And then it's also important to distinguish, are we using tests that help us to detect polyps, or are we using tests to help us to detect cancers? And they differ a bit. So colonoscopy is really the gold standard for both cancer and polyp detection. There are many large prospective studies that show reduction in colorectal cancer mortality by using colonoscopies. The disadvantages are that it's invasive. So I'll have, many of us in the room have maybe had colonoscopies, but it requires the use of a preparatory agent or drinking a lot of fluid to kind of flush out the colon. So that's the bowel prep. It can require time off work for patients, and it also requires sedation. A flexible sigmoidoscopy, as I'd mentioned, only captures or only investigates part of the colon. This is a slightly easier test. It still requires some bowel prep, but it is a bit easier. It does not require sedation. The advantage is that randomized controlled trials do also show reduction in colorectal cancer mortality. And then there is something called the virtual colonoscopy, or a CT colonography. If Anne were still here, she could comment some on that. It's actually using CT scans to create 3-dimensional reconstructions of the colon to look for cancers. The advantages are no sedation and it's non-invasive. But the disadvantages is that if you find or detect some abnormality, you then subsequently have to go on and get a colonoscopy. So then it still requires initially time off work and then perhaps even a subsequent colonoscopy. So the stool or fecal-based tests, many of which have been around for a long time. So the fecal occult blood test is a test that is non-invasive. It basically tests stool for the presence of blood. There's no sedation required, no bowel prep required. The cons are that it's less likely to detect polyps for cancer prevention, and its sensitivity is limited by how the specimen is collected. So studies have shown that these specimens are frequently collected incorrectly, or the number of stool cards that are collected are inadequate. So it's randomized controlled trials do also show a reduction in mortality. This is often used more frequently in developing countries. Its cost is significantly less than the colonoscopy. There are some developing tests. So there's an immunochemical test called the FIT test that directly detects hemoglobin, a component of blood, and a single sample for that is adequate. And then there are additional tests being developed to detect DNA-based changes of cancer predisposing genes. And it's an emerging tool not used routinely, but I think, as Alice had mentioned, making use of genetics or molecular changes both in polyps and cancer is probably one of the directions that we'll head in terms of screening. This is worth just taking a look at. So this is a table that shows both costs and test characteristics of adenoma and colorectal screening. So sensitivity is a way that we describe how we can detect the true positives for detecting both polyps and cancers. So colonoscopy is the gold standard. It has sort of the most favorable test characteristics, both in terms of detecting adenomas, that's that precursor lesion to cancer, and in terms of detecting cancer, though it is by far the most expensive. And then you can see the subsequent ones that we've talked about in terms of virtual colonoscopy, flexible sigmoidoscopy. One test we didn't talk about in terms of detecting primarily cancers is a barium enema. So that's a tool that our radiologists will help us use by inserting a liquid into the rectum that helps determine and detect abnormalities in the colon. So the screening for average risk patients has, there are actually a number of guidelines that exist. including the American Cancer Society, multi-society task forces, the USPSTF, which was mentioned earlier, the National Comprehensive Cancer Network. But just the take-home point here of the Venn diagram is that the gold standard and by far the best tool to screen patients for colon cancer is the colonoscopy. I'd like to just introduce you to the NCCN guidelines, which are actually a great tool for both medical providers and patients. It's nccn.org, and they have both lay-friendly and physician guidelines for cancer treatment, but also for screening. So this is just a snapshot of one of the pages from the colorectal cancer screening guidelines for average risk patients. So these are not the patients that have other indicators of high risk. So you can see their risk status, so average age over 50, no history of adenoma, no history of inflammatory bowel disease. It then marches you through which screening modality should be used and on what schedule, and then based on what the findings are, what the subsequent screening interval and modality that should be used. So very useful. And all of those guidelines are written in the form of algorithms, so they're very useful to follow. So in terms of screening for increased and high-risk individuals, there are very similar algorithms. I'm not going to go into the details, but only to say that the interval at which colonoscopies are recommended is very different for these high-risk individuals. It typically is on the order of 3 to 5 years, rather than every 10 years for an average risk individual. So increased risk is defined as a personal history of polyps, personal history of colorectal cancer, inflammatory bowel disease, and family history. The high-risk individuals are these folks that meet those revised Bethesda criteria for HNPCC or Lynch syndrome, or have greater than 10 adenomas in the same individual. And there are some additional other inherited syndromes that are included in this. And just to make a few comments on colorectal cancer screening in women. So as we all know, women comprise about half of the U.S. population, but given that women are living longer, they are going to represent an increasing percentage of the U.S. population over time. So they represent 57% of the U.S. population over 65 and 66% of the population over 85. There are no sex-specific screening guidelines for colorectal cancer. Interestingly, uptake of screening in women is lower than in men. In this study that I quote here, it's just by a couple of percentage points, but it differs in various studies. The lowest rates are in Asian women and in Hispanic women. And in terms of future research, specifically on prevention and taking advantage of some of these special molecular features, there has long been interest in whether or not NSAIDs, so anti-inflammatory agents like ibuprofen, in this particular trial they're using an agent called celecoxib, can we use these anti-inflammatory agents to both reduce the risk of polyps and reduce the risk of secondary cancer development? So this is actually a big national clinical trial of hundreds of patients with colon cancer who have what's considered a stage 3 colon cancer. Stage 3 colon cancers, by definition, after they've been removed, require getting chemotherapy. And this study also incorporates the use of half the patients get this anti-inflammatory medication celecoxib, and the other half do not. So this will be a very important study to both follow and answer the question around polyp prevention and cancer prevention. And there are some treatment clinical trials that are taking advantage of some of these unique molecular features that I'd mentioned to you. So the microsatellite instability that I'd mentioned, that's a hallmark of HNPCC or Lynch syndrome, is now being studied in terms of treatment trials. So do some of these patients, will they respond better to certain treatments or less to others? A very hot area in the field of cancer treatments is immunotherapy, which are ways to help harness the immune system to help fight the cancer. And there's some thought that patients with MSI high tumors may actually respond better to immunotherapies. So some of the take-home points are that all average risk persons age 50 and older should begin regular screening. Screening for sure saves lives. It reduces colorectal cancer mortality. There are several effective screening tools available, though we generally recommend colonoscopy. There are actually a number, and some of those options can be tailored based on the actual patient. Early cancer detection saves lives. And I think I'll just echo, I think as I was preparing the slides for today, there's very little sex-specific research on screening for colon cancer. And I think that that's, as I was reading more about that for today, I think that that's certainly an area that needs more research. So I'm happy to take a couple of questions. I know we are running a little bit behind.